Good morning. I'm Dr. Trudy Larson, and this morning we're going to talk about one of my favorite topics, and one which I'm hopeful will inspire a few folks to begin testing. So here we go. We're going to talk about routine screening for HIV, and I'm going to go through the rationale of why screening is really, really important, and then how you might incorporate it into your regular care. So we're going to start first. This works for me, yes. Okay, we're going to set the stage here with a case. So here we go. You get a phone call from the health department that one of the pregnant women you follow tested HIV positive. They wanted you to know. At the appointment the next day, she tearfully states that she's been married for 10 years, can't imagine where she got this. She denies any other sexual contacts during her marriage, but had many contacts before she was married. She denied any drug use. Her labs show that her CD4 is 35 and her viral load is 48,000. And that's very low, so she's had this for quite some time. The health department helps with partner testing, and the following scenario unfolds. Her husband tests HIV positive, don't know if it's new or old, and names his prior wife and 2 partners as contacts. His prior wife is negative, but one of the 2 partners is HIV positive. All are newly diagnosed. So what happened? Well, what happened is that no one in this entire scenario was tested previously. Unsafe sex happened. There was no opportunity to intervene. There was no opportunity to really reduce the risks of disease progression, and there was no opportunity to impact transmission. This is not an uncommon scenario. And in fact, in the pregnant women I see, it's all too common for them to not know that they're infected and to be very concerned, as they should, about their babies and their partners. So what I want to talk to you today is why HIV screening should be part of routine care. So to start this conversation off, the National HIV/AIDS Strategy is very clear in their goals. And it's first to reduce the number of people who become HIV infected. It's a very lofty goal and very difficult. But our conversation this morning is really a critical part of that. Increase access to care and optimize health outcomes for people living with HIV. It's also very important. Reduce HIV-related disparities, discrimination, and stigma, which is a really important piece of this testing, and achieve a more coordinated national response. This is really designed to reduce HIV infections in the United States and hopefully make us more closer to a goal of no new infections. So there's huge challenges here, and this is called the HIV care spectrum. And what this looks at is various numbers of folks in various stages of engagement in care. And so just to point it out, on the far left, that's how many estimated HIV-infected persons that we see. So let's say 1.2 million folks who are truly infected. Of those who are truly infected, only 941, almost 42,000 actually know that they're infected. So that difference is because of not being tested. The next one is being linked to care. Of those who are diagnosed, how many are linked to care? So you see another significant decrease there. Of those linked to care, how many are retained in care? Another decrease there. That's a huge challenge to keep people engaged. And then of those in care who are coming, and this is at least 2 visits in a single year, how many are on antiretroviral therapy? A larger fraction there. And then at the end here is how many of those are adequately managed so that viral loads are undetectable, which is our treatment goal. And that's only 28%. So this is actually, our goal is to have everybody with HIV optimally suppressed for 2 reasons. One, their own health, and the second reason is because of transmission. So the recommendations from CDC, these came out over 10 years ago, that HIV testing should be done routinely. And they noted that this should be in public and private settings, and they called for routine testing in a variety of sites: emergency departments, urgent care clinics, inpatient services, substance abuse, public health clinics, correctional health care facilities, and primary care settings. This is over 10 years ago. And they recommended that testing of all persons aged 13 to 64 be part of this screening effort, which means they are not identified at risk. This is just screening to find out if they might have been infected sometime in their past. In addition to that, the testing recommendations also state that for people with ongoing risk, either sexual or drug use, drug sharing, that this get done on an annual basis. But for folks who don't have any ongoing risks, this one time is really important to make sure that they didn't get infected in the past and that they don't end up really sick. Now the screening has been endorsed by the U.S. Preventative Task Force, which means it's paid for by ACA. It's mandated by ACA because the task force said that, and they have a slightly different age range, 15 to 65, should be tested at least once for HIV. And you know, when the U.S. Preventative Task Force actually makes those recommendations, it is based on a lot of data. They look at the cost effectiveness, and our tests are so sensitive now that the positive and false negatives are very, very low. So this is the screening recommendation. So why should everybody be tested? First of all, you saw in that first cascade that about 15 to 20% of people living with HIV do not know they are infected. And that's simply because HIV really has a very long period of time between the time you get infected and the time that, that you get symptoms. And the average is 10 years. So it's really not uncommon for people to come in and say, I had no idea. And for that scenario we started with, for a woman who's been married for 7 or 8 years, to have brought this infection with her because of past behavior, but not having had any risky behavior during that period of time. So asymptomatic, very long period, all that time there's virus in the blood, and a person is infectious. So long period of time not knowing that they have HIV, and testing is the only way to identify this, unless they're in advanced cases of AIDS where they have all the symptoms. So a test is absolutely necessary to diagnose HIV. Early entry into care is also a critical feature because it's now shown that people who enter into care earlier and are adequately treated with an undetectable viral load can expect to live a normal life. A normal life. That's unbelievable. But that's how potent our medications are now. And so we want to get folks in early so that we can really address the immune deficiency issues and get their immune systems built back up. We don't do very well with this because almost 40% of persons who have HIV are not diagnosed until they're in the late stages of disease. And so that would be somebody who's hospitalized with an unusual pneumonia like pneumocystis, and they have no clue that they had been infected for all those years. And so we hate it when that happens because it makes it more difficult for them to recover. And then the other thing that's very important is transmission is very much directly related to knowing you have HIV. So it's been shown over and over again that people who know they have HIV are more likely to engage in risk reduction efforts and not put others at risk. So knowing your serostatus, as we call it, that's testing, is really critical for transmission. And this is a study that looked at new infections and looked at people living with HIV/AIDS, and you can see here that the 25% of those who were unaware of infection in this study sample were responsible for 54% of the new infections. And so really, for transmission to be interrupted, for us to really be able to address HIV nationally and the large figures that we already have, that people get tested. The other thing that's very important is that as we know that viral load numbers are directly related to transmission risk. And this is a very old study, you see it was published in 2000, that says if your viral load is high, for instance, like over 50,000, that your transmission rate per 100 person years is much higher than it is if you have almost an undetectable viral load. And so you can see that there's really an important reason for people to get diagnosed, and treated, because they're not going to be transmitting HIV to others. And that's a real critical public health issue now. So, routinely also means that you take out a perception of risk. So if you do this with all of your patients, this is a wonderful way to reduce stigma and increase the rate of diagnosis, because it simply says, I test everybody because these are the recommendations, and it's not because you're doing something bad that you need to worry about, which is the perception on the part of patients. And I don't know if any of you have ever been tested for HIV, but it's an interesting process to go through, and you do feel a little uncomfortable, but it's really, this is the step that's critical for this. And it's difficult for us to do those risk assessments to really identify if there's risk, sexual risk, or if there's drug use, drug sharing risk. So if you screen everybody, then at least you don't have to talk about risk. Although I will warn you that if you talk about HIV at all, like I test all of my patients for HIV, I just want you to know that, that may open the door to conversations that you didn't know you needed to have. And those are really important conversations. Because risk prevention is really rarely addressed. It's not a topic that most of us like to talk about, and it's complicated. So testing offers an opportunity to discuss some risks that folks may have and have not wanted to talk to any of you about. So, do providers ask about risk? I love this study. This is a study that looked at different types of providers. So on this group of columns, we have primary care, we have infectious disease clinics, we have HIV clinics, we have a public clinic, we have a private clinic. So does anybody want to guess who that nice tall column relates to? Who do you think really routinely asks about risk? Any takers?
Public clinic.
Public, okay. I think that's a pretty good guess. I think most of us would say, yeah, of course they do that. Well, watch this. I'm just going to put them all out here so you can see. So, primary care providers were the ones that did this the most, and private physicians the next, then non-ID trained physicians, then ID trained physicians is disgusting, and then HIV care providers. First, the primary care providers was actually public, and the HIV care providers even worse. So the point is that nobody really likes to talk about this, and so by using this in a routine fashion and screening with blood work, then this particular difficult questioning may need to go away. And this is a quote from The Hidden Epidemic by the Institutes of Medicine. Ironically, it may require greater intimacy to discuss sex than to engage in it. And I think this is an issue for many providers. It's not a comfortable topic at all. And so when it comes to testing, you actually don't need to talk about this before you test if you're going to use this in a screening fashion. Now, why do we talk about HIV in Nevada? Because Nevada always is a dark purple. Not the darkest purple, but a dark purple. And so we're very comparable to California in terms of our rates of HIV infections. And it's been that way since the beginning. So we do have a fair amount of HIV in our state. Not a lot of numbers, but these are rates because of our population size. And who is it that gets HIV? Still, it's mainly male-to-male sexual contact is the primary way of transmission. Injection drug use has gotten smaller for males and females, and heterosexual contact has become a little bit bigger. But you see the difference between men and women. For women, it's far more likely that they get infected through heterosexual contact, which means they may not self-identify at risk. And for males, it's primarily male-to-male sexual contact, and that's an important feature to understand about your patients, because there are other issues then that need to be addressed. So this is sort of what it looks like, transmission patterns. So our HIV tests have undergone some changes recently. So the standard blood test is the HIV ELISA test, and for years a Western blot confirmation was used. Now they don't use Western blots anymore. It's cumbersome, it takes a long time, So that is being phased out, and an antigen test is being used more often. So they look for P24 antigen as a confirmatory test. And these can be done now with rapid testing. So the rapid testing is about 20 minutes maximum. There are a number of different testing kits. Some are oral fluid, some are finger sticks, some of them actually require serum. Those are the ones that are typically used in hospitals because they're very fast, but it's oftentimes easier just to grab a big blood specimen. But you can do it with the finger stick, and that's often when folks do outreach and are trying to do testing in the community, they use the finger stick because it's really fast. And then with rapid testing, the huge benefit is that you'll have an answer and you can address it immediately. Now remember, a negative test is an excellent talking point as well, because folks may want to say, you know, I was really scared about this because I had lots of sexual partners and I was really worried, so I'm really glad it's negative. But it's an opportunity then to talk about safe sex. This is currently the 4th generation HIV antibody test, and it incorporates antigen into this test. So this is like this is the most sensitive test. It picks up infection between 4 to 6 weeks after it happens. And you can see here is that it will test for both 1 and 2 types. And you can see if it's negative for HIV 1 or 2 antibodies, that's what it tests for, and P24 antigen, which is a piece of the virus, then that's a negative test. But if it's positive, you can see there's a number of ways that this looks at. But if you have a positive antigen test, that is a pretty powerful tool to ensure that this is really test. We still do another rapid test to confirm a different type, but now we don't have to use Western blot, so this could be a lot faster. People who get this first positive test really, really want to know. But the 4th generation is a far better test, and that's what's coming out more, is being used more and more now. So how do you implement this? Because, you know, patients always have a right to decline any test. Well, opt-out testing is what is recommended. So you do this for all your patients, but they always have the ability to opt out. So a test will be performed unless a patient specifically declines. All patients should know that the test is being done. So if you're getting a blood panel for lipids or a CBC to check for anemia, and you decide this is a great time to do the HIV screen, you need to let them know that that's what it's going to be. The CDC recommends that you can provide some written instruction at the time that includes, you know, what HIV is and ways to prevent it and the meaning of a positive and negative result. And that's a very fast way. It doesn't take a lot of time. It provides some opportunity. If you're doing rapid testing, they can be reading this while the test is being conducted. HIV testing should always be voluntary. People should always have an opportunity to not do it. And if the patient declines, you need to document it in the chart. There are a lot of reasons for this because best practices now are clearly to screen for HIV. And if somebody has HIV and they were not offered testing, or they transmitted to somebody, and there may be issues legally actually anymore if it's not documented they refuse the test. It gets complicated, as you can well decline. And so you could see, so like during pregnancy in particular, this would be a place where you'd really want to say the patient declined to take the test in pregnancy because of the potential risk of transmission to babies. Now the important thing for everybody to know is this does not require a special consent. You do not need a special consent form. You don't need to do it. You know, it's just part of routine, care for any patient. So your general consents for treatment, which patients always sign, that will suffice. You don't need anything special. And all of these are designed to make this an easier, faster process for implementation in routine care. There's a lot of barriers for testing that have been identified. Personal barriers is on the part of patients. They don't know about HIV and Ris. They may not have ever been asked if they want to test for HIV. They may fear the results because perhaps they've had a lot of risky behavior in the past. And so that can be very scary. And they are also may be very worried about the cost of tests and the concern with the cost of being HIV positive if they have had risk activities in the past. All of these things can really be addressed. I mean, the tests are not very expensive anymore, and that's important for them to know. So it's inexpensive. By the ACA law, this has to be covered by insurance, and that's very important. So getting this kind of a screening test now will be paid for. Fear of the results, we all have fear of results. Some of us, get concerned about many things on our lab tests. Well, this may be just one of them. For other barriers, they can be institutional or physician barriers. Discomfort with HIV testing, not wanting to have to talk to your patients about it. And it may be a little difficult, like for your 62-year-old patient saying, well, maybe we should test you. But I have to tell you, the fastest growing group now of those with HIV are over 50. The fastest growing. And I think a lot of it has to do with the fact that they all grew up in a time of, this was a new time of free love, etc., and they don't do a very good job of negotiating safe sex. And so we start seeing more, we're seeing more HIV positive tests coming back in those who are older. So discomfort, absolutely, it's still the important thing to do. It is not time consuming anymore. It's not costly anymore. And there are lots of resources. If the test is positive, there are a lot of resources. At Northern Nevada Hoax, we still have our specialty HIV clinic, and we see patients from all over Northern Nevada. Southern Nevada has they have a number of large HIV clinics there, so there's lots of help with taking care of patients with HIV. So again, back to our challenge. Once we get them tested, so that's that first column to from undiagnosed to diagnosed. That's all about testing. Then there's a lot of other things that have to happen, getting them in care, retaining them in care, getting them on antiretroviral therapy, so that we meet our goal of undetectable virus. So why do we want to do all this? Well, benefits of early therapy have been shown clearly. There's earlier suppression of viral replication, which means the immune system is preserved and it's not further degraded, and prolongation of disease-free survival, that's also really important, and a decrease in the risk of HIV transmission. So the earlier the better for HIV, much as it is for many of our diseases, before some of the more difficult complications occur. So I want to do a little, talk a little bit of one of the studies that was very instrumental in talking about when should we start ART. There's been a lot of debate about starting antiretroviral therapy. And so what they did in this study is they stratified patients into two groups. The first group had, the first group had treatment started or had treatment continued no matter what their CD4 count was. And the other group were interrupted or deferred therapy until their CD4 cells went below 250 cells. And this was when there were toxicity issues that were worrying folks with taking antiretroviral therapy. So we have an immediate and a deferred treatment group. And they looked at this study in follow-up to see what would happen. It was it's a large study, and they halted this study early because it didn't take very long before they were able to show that patients who were immediately treated and remained on ART at higher CD4 counts had far better outcomes than those who were deferred. And the better outcomes were in deaths. The deferred heart was 15 deaths versus 4 in the immediate heart range. And then overall and serious non-AIDS, and then the composite was quite powerful. And if you look over on your far right, you can see that every single measurement that they looked at favored immediate ART implementation, which means they have to be tested. You have to know that they're positive in order to start this. And one of the most important things about this is that serious non-AIDS events, these include cardiovascular disease, renal disease, that is very much impacted by starting ART early and reducing inflammation. So we have very potent and highly tolerable antiretroviral therapy now. Most of our medications are delivered as one pill once a day. It's a triple combination pill with the three different medications, and it requires 3 to fully suppress this virus and overcome the resistance development. So very potent, very easy to take. It preserves immune function. When the virus goes down, the CD4 cells, that's what we measure, that immune cell, CD4, goes up. And our patients then are protected from immune deficiency diseases. When that happens, of course, there's a reduction in going to AIDS, because that happens at the later stages of HIV infection when you actually get AIDS, and that's when you're really sick. And then non-AIDS associated morbidity and mortality having to do with the cardiovascular disease, cancers, and renal disease. Those are the 3 big ones that are also impacted by the use of ART. And that really, the mechanism of this is that when you treat HIV and get rid of the virus, it also stops the inflammatory response. And inflammation, as we are all learning, is the final pathway for a lot of very complicated diseases. Cardiovascular disease clearly is associated with inflammation, as are numerous other conditions. So this inflammation goes down when treatment occurs, and that begins to address and slow down the acquisition of these other non-HIV, non-AIDS conditions. So people get healthier for a variety of reasons. For the public health aspect here, it's a major reduction in HIV transmission, and these are durable, tolerable. For patients who are adherent, as with all of our treatment, if they are adherent and take their one pill every day, they can be on the same medication for their entire lives. It's very durable, it's very tolerable, and we don't have to worry about 12 or 13 different pills. As they age, then they may be adding on diabetes medications and hypertension medications and things like that. But with one pill once a day, it's really easy. So there's really no reason now for people to be fearful of the treatment, because it's so much easier than it used to be. And it's such a potent outcome for those with HIV. So when we get to that viral suppression on the right is also when we begin to have significant impacts on transmission rates. And so testing starts this process and really allows for early diagnosis and for the ability to implement more prevention options to reduce transmission. There's a lot of very innovative testing initiatives to try to reach people who may not ever access the healthcare system. They're very clever. Things on mobile apps and that tell people where they can go get tested. There's prevention with positives. Clearly, that's something I do regularly in my HIV clinic, where I talk to my patients about ways to reduce transmission to others. So that's a behavioral risk issue. We all know how difficult that is. So knowing that we have a biological intervention with treatment, so now we have treatment as prevention, has been really, really helpful for patients. So now they may not be able to change their behavior, but if they take their pills every day and they're undetectable, they are not going to transmit this virus to others. And that's a huge benefit of treatment. There's also the use of PrEP, and I'm going to talk a little bit about that because you may have patients talking to you about PrEP, pre-exposure prophylaxis. That's a real new initiative. And clearly you have to test before you put somebody on PrEP because it's not adequate for treatment. So let's look at transmission. Here's a study that was done. This is a worldwide study, and what they did is they looked at partners, serodiscordant couples. So one was positive and one was negative, and they looked over time to see the impact of the use of antiretroviral therapy on transmission. So what they were able to do, within this very, very large group, they had 39 transmissions. Of those transmissions, they linked them. Did they both have the same virus? And so the linked transmissions where they both had the same virus, you could see one was in the, almost all of them were in the delayed arm versus the immediate arm. And the immediate arm had one, and they really felt that that occurred close to the time that therapy began. So it may have not been able to stop that transmission. Interestingly, of course, unlinked or other transmissions, so not between those two folks, there were a number of those. But I think this is a really important study that says when you put people on antiretroviral therapy who have HIV, they don't transmit. And this has been a wonderful study for me to share with many of my patients. It really motivates them to continue to take their medications in a very adherent fashion. Now, what about PrEP, pre-exposure prophylaxis? This was the biggest study that was done on this. To be in this particular study, they had to be over 18, gay men who had risk. And you can see they're a relatively large group of folks that enrolled, 2,500, and they were almost equally distributed between a placebo group and a group that took Truvada, which is a fixed combination of two reverse transcriptase inhibitors. You don't need to remember that, but it's called Truvada. And this is the same medication that was used in the prior study, Truvada. And so they enrolled them both before PrEP, during PrEP, after PrEP. They were able to look at total number of infections. And so you can see that in the FTC, the group that took Truvada, there were 54 HIV infections. In the group who took placebo, there were 93 HIV infections. So more. It's not what we would like. We would like to see a lot better. It certainly was a lot better in the heterosexual couple transmission study, where it was 96% effective. But what they were able to identify, this is an overall efficacy of 42%. However, in those that actually had drug on board, so they took blood specimens and they could actually measure Truvada in the blood, it was much closer to 80% reduction in transmission. So like all of the other medications, it was very clear that for this to work, you have to take the medication every single day if you are going to have ongoing risky behavior, and it will be effective. So this is called PrEP, pre-exposure prophylaxis. They also looked at PrEP in another cohort, heterosexuals in Botswana, where they had placebo versus oral Truvada 12-month follow-up, and they showed that it significantly reduced HIV acquisition. So the first study I showed you, the 96% were in couples. So they were couples who had been together for a very long time. This was just those who are heterosexually active were able to have a significant decline in transmission, 62.6%, with the same caveat for those who actually took the drug, they were protected. So PrEP is important for those who have ongoing risk. And the target groups for most of our testing have been young, gay men who have very high rates of acquisition of HIV, because PrEP is something that's really recommended for them. Also, PrEP is recommended for heterosexual couples where one is serodiscordant, like one is positive, one is negative. And so that's another really important component of getting the test done. So this challenge is ongoing. What we would like to have happen is that far right column goes up substantially. So all the columns go up so that we're able to get the diagnosis of HIV done in almost all people. And with routine testing, that will happen. That will happen in routine testing. So back to our case. Even though the pregnant woman has AIDS because her CD4 count is less than 200, she is put in antiretroviral therapy during her pregnancy and successfully delivers, by vaginal delivery, a healthy, uninfected infant girl. So testing in a pregnant woman and a positive test then leads to immediate use of antiretroviral therapy, which is highly effective in preventing HIV transmission. So she had a healthy, uninfected little girl. The husband, who also ended up being positive, enters care. He's supported in his adherence struggles, because it can be difficult, by his wife and new daughter, and in 6 months has a viral load less than 20. His prior partner, who was also HIV positive, was in denial and declines treatment. She said, oh, maybe when I'm sick I'll get treated. But her current partner decided to take precautions and remains uninfected. So this all started with a pregnant woman getting an HIV test and having all these people who were already infected finally getting diagnosed and being able to be treated effectively. So testing is the key to starting this cascade. And routine testing should be implemented whenever a patient is coming in for any sort of screening, routine, follow-up, for a lot of reasons. It really provides the opportunity to link to care and treatment, reduce morbidity and mortality for them, reduce transmissions through treatment and through behavioral changes, and allows those who are negative to take steps to reduce their risk. So that is the end of my presentation, and I'd be happy to take questions. Have any of you tried to implement HIV testing in your clinics? Like routine HIV testing?
Zero?
Zero, yeah. So that is not uncommon, because I have to tell you, even in our HIV clinic at HOPES, which now is a federally qualified health center, and we see all sorts of patients, it took a year to put a process in place where everybody is now being offered testing. So it's really, some of the logistical challenges are important, but we've been working with CHA here, the Community Health Alliance here in Reno, to also implement routine testing in their patient population, and they've all had training. The MAs all have training. They're using rapid tests so that they can really get it done fast and be able to report back to their patients immediately. And although it takes a bit of time to get started, they're really starting to get that going. And at HOPES, it's the same kind of thing. And we've been sort of surprised that we actually already picked up a positive for those who were screened.
When you're doing your screening, do you need to use a special reimbursement code, or does it just fall underneath your normal coding? How do you guys do that to make sure you're getting reimbursed?
Yeah, there is a code for routine testing, yes. And so that is absolutely what you want to use. And again, it is by ACA included in screening. So there is a code. Yeah, there's a specific code for HIV routine testing. Yeah. What kind of issues do you foresee in your offices or your clinics that might get in the way of beginning to do this?
In our clinic, we have a little box when they first come in that they check if they want to be HIV screened or not, just as they're filling out their history and everything. And then when they do come back, most of us don't even realize to check and look at those boxes once they've passed them back. So just bringing up the fact that they even want to be tested, they don't usually get tested afterwards.
So one of another way to consider this is routine really means not asking for permission, but saying I do this with all my patients and it's my routine, and so having them opt out of a test. And so what we do is we have our MAs actually start this process. When they go in and say, in our clinic, we routinely test for HIV when we do regular screening tests, and so we just want to let you know. And that has been very favorably received, as an affirmative, rather than asking permission, just saying we do it, and then if they don't want it done, no problem at all. But it is an opportunity to bring this up. And again, it's very interesting to me. All they need to know is that they could have had this for years and had no sense of having it at all because of past exposure. And so you just need them to be tested once to find out. And if they're in a mutually monogamous relationship going forward, then they don't need to be tested again, which is really wonderful. But it really is that it's a really weird kind of thing. But we think nothing of testing for cholesterol in a screening manner. We're doing our FIT tests all the time now. And I don't know, collecting poop or getting a rapid test in your finger, I don't know. They're both a little uncomfortable, I guess. But, you know, it's the same, it's that whole process that we recommend these things to people because it's in their best interest. And they always, again, have the ability to test out. So I would sort of challenge you to say, to seeing how you can then move that whole thing. Like, these are the recommended screening tests that we do in this clinic. Be happy to discuss any of them. Maybe as a more affirmative way to start that conversation. But you do have to look at it. So we always have our MAs do that because they tend to be much better at fighting things than we do. Have any of you had patients that you were surprised when they had an HIV positive test? Well, I mean, I can answer yes, I've been surprised. And so to me, that's one of those things where, you know, we make massive assumptions at times. And that's the other thing, you have to sort of suspend assumptions when looking at the whole issue of screening. You just do it for everybody regardless of whether you think they may be at risk or not. Certainly, you may want to talk it up a whole lot more when you have young gay men that are that you're seeing, or if you have folks that have a lot of unprotected sex, you may want to bring this up in a more affirmative fashion, saying, you know, this would be really good if you decide this. So you need to be a little bit more forceful with them because they are part of a targeted high-risk population. But clearly, the screening is just another way for folks to not feel like they're being identified at risk. Thoughts?
Okay. Hi.
Hi.
So when I was in my residency, we used a app called AHRQ, the EPSS app for like the recommended US PSTF recommendations, and I find that helpful with some people when you enter the information and you can actually show them. Look, this is a screening recommendation. So that might be something other people can use.
Yeah. No, I think that's great. And I mean, when the U.S. Preventative Task Force finally made that recommendation, it made a big impact on a lot of people. So clearly, now insurance covers it because of that. But also, I agree with you. I think that's a really good way to do that.
I mean, by a show of hands, is there anybody that isn't going to implement? I mean, regardless of the information that's out there, or not interested in screening? You got one, Emily?
No, I just had a question.
Okay.
You know, of course, I want to implement this in my practice. I think that that's interesting. I'm a student, an FNP student, but I currently work in the ER, and I was just curious, like, I kind of feel that most of the providers really hesitate to screen for that, even in the ER, because, and the theory, I mean, what they've told me in the past is that there's so limited resources and there's nobody to follow up with, and if they're positive, then how do we, you know, get them to follow up? What are your thoughts on that, you know, given all this information? Because this seems like that's kind of maybe old school thought.
Yeah, it's very old school thought, but I have to tell you, implementing routine testing in ERs is very, very difficult. But when they have looked at studies where they look at, you know, if you do ER testing, do you find people who are HIV? And they're far higher percentage in ERs than anywhere else, which you would think. But so it's very clear that that's a very important place to do it. And what has been implemented in some emergency departments with great success is that they have an outreach worker who can sort of be on call, or they can train somebody who can provide the resources, give a little bit of information, set them up with an appointment. I mean, it's pretty easy anymore to get folks in for follow-up appointments. And I know a lot of people are very concerned about that, like, oh my God, I have a positive test, what am I supposed to do with this? But it's easy to get them in. So a variety of people can take that role of being that navigator, of giving the resources, of helping them make the appointments, and I think that's a really critical way to manage this. And so I totally understand why it hasn't been implemented, but I think it's really important because that actually is a population that is at the highest risk in terms of where they've looked at positive tests in the past. But it requires a culture change. It requires education of the entire medical team, and then it takes, when you implement this as screening, that everybody knows what that really means, and then who takes responsibility after that, and that there's a clear follow-up. And so when we did this with Community Health Alliance here, we have it all, if you get a positive test, they call HOPES, we're open at the same time, so they call HOPES, we get somebody on the line that they can talk to, they set up the appointment immediately, and bingo, there's a follow-up, our case managers get on it. I know those resources are not always available in every office, but certainly the way that medical care is beginning to change with that whole team approach, you can have some member of the team responsible for that. So I think it's going to happen. I think there's going to be a lot more navigation done in emergency departments because they're going to need to do that simply to take care of a number of different things. So that's a really important question.
I just have a few more questions. So I went to a talk last night about hepatitis C, and they're really pushing the same thing, making hepatitis C part of routine screening. When we send you guys a patient, I know we've sent you a couple in the past, what screening would you like for us to have done before they even get there? Besides, normal CBC, CMP, would you like all the hepatitis screening done? Or is it easier for you just to do it there? What would you like the patient to show up with?
So for HIV, typically the only things that we're interested in really are the CD4 count, which is a helper. They call it a helper CD4, CD8 measure, and an HIV RNA quantitative. Those are the two things that are extraordinarily helpful because that allows us then to start therapy on the first visit. Typically, we'll get all the rest of the labs when they come because there's a whole bunch of things that look for, past hepatitis, exposures, and we look for toxoplasma, we look for a whole bunch of other stuff. But that is more looking at what can happen with the complications later. That's not critical. The two critical labs are a CD4 count and a viral load. For HIV. Hep C is a little different.
And then are you seeing a lot of places doing like a package, we're just going to test you for this stuff. You're going to get the Hep C, you're going to get the HIV. Do you see a lot of places doing that, or do you have a better luck just addressing them individually?
Those are really great questions, and it's an evolving field because we're all struggling in our clinics on how to do this. And so because at HOPES we see hepatitis C and HIV, I think it's far easier for us to implement those as routine screens by all our primary care providers in the clinic. So that's sort of a routine policy for us. But that's because we see it, so it's very real for us. I don't think that that's always so easy. That hepatitis C screening is really important as well, and doing the two together just says, we just want to make sure sometime in the past you were not exposed to this. And I would actually think doing it together. HIV, you could do a point of care test if you want to. Like that's what we do in our clinic. We do a point of care finger stick test at HOPES for HIV, but they don't have that available. Perhaps C it really requires, you know, a blood specimen. But yeah, the two big ones are the CD4 and viral alert for HIV. And I think people wait on that, of course, until after a positive test, and then would order that.
Are there any more questions out there?
Any more questions, anybody? Well, I really want to thank you for joining me nice and early and bright and early in the morning. Is there another question?
Luis, do you have a question?
I don't. Thank you.
Okay. I want to thank you for joining me this morning. This is a topic I think the evidence is very, very clear, but I think the implementation is not so easy. So good luck with that. Where I'm available by email, I'm pretty good at that. It's tlarson, and that's LARSON @unr.edu. If you have questions about this, I'd be happy to answer any of them.
Thanks, everybody.
Thank you.
Thanks, Dr. Larson.
You're welcome.
Thank you.
You're welcome.